Welcome to the Hammersmith Hospital, and we've got a fascinating case for you. You will have seen the history already, but in brief, a terrible case of infective endocarditis, both on the aortic and mitral valve with a root abscess, and a fantastic save by the surgeons who replaced the aortic valve, the mitral valve, put a patch on the aorta. Initially, he did quite well. A few months later, he presented with flutter and was in heart failure. And at that stage, it was noted that there was a really dramatic jet going from the LV to the LA. Now, you would think that that was a paravalvular leak, but actually, I think it's more interesting than that, as we'll see in a second. So let me introduce the team. Neil Ruparelli is with me, myself, Iqbal Malik, Chris Cook, our fellow, the fantastic Cath Lab team, Bushra Rana on echo. So we've got amazing echo, and Claire Boyd and our anaesthetist who's keeping the patient very stable. So that is the team, and there's a lot to discuss here.
Obviously, there's a lot of shadowing here. You can see the right heart's quite enlarged. But we're going to focus on the mitral valve to begin with. There's a tissue mitral prosthesis. You can see the leaflets, which seem to be functioning well. You see a lot of regurgitation in the left atrium, but it's not clear exactly where this is originating from. So if it's coming from the valve, it certainly seems to be over the top of the valve here, but if it's coming from the valve, I need to find its origin. So I'm looking for the flow convergence and the vena contractor. So we're going around the degrees. And as we do, you've already seen actually where the jet is coming from and originating from. I'm just rolling the probe just to give you some idea of that. So it looks like there's actually a jet, not from the valve itself, but in fact from a lesion at the sewing ring edge of the valve. So as you know, this patient has had both tissue, AVR, MVR, and also had a root abscess and ended up having pericardial patch as well. And so if I just stop here, just going to orientate you. So you've got the mitral valve prosthesis here. You can see we're doing some contrast injection in the aorta here. You can see the aortic valve prosthesis here. You can see the leaflets moving. I'm just moving the probe around. But what's interesting is if you look at this region here, so from the aortic root, where the left atrium would be above, and then as you follow that line to where you would expect the mitral valve to be continuous, so the aortomitral curtain, you can see that actually there's a lot of irregular tissue. You can see here, in fact, there seems to be a layer of tissue here. And if we follow that up, it looks like there's a blind ending pouch. And then as we follow that edge right down to the aortic side, you can see here there's an irregularity here. So just to understand that better, if I put some colour on, so I hope you can clearly see there is a large defect in this tissue here, which we think is the patch, and you can see a lot of regurgitation coming from the outflow tract into the left atrium. A little bit more information before I go to 3D. So if I just use X-plane, what we immediately see is above the aortic valve prosthesis, you can see the tissue, you can see the struts of the valve, you can see the leaflets, you see the root here, but above it is that area that we saw, this blind ending patch that we pouch that we talked about. And interestingly, it looks like there may be little threads of tissue here, so it may be loculated. But remember, this patient had quite a bad abscess. So as we move down, we follow it down. We've come to the level of the sewing ring now. But if I just move back slightly on that, let me just show you something else that's important, an important landmark. So as we move down, can you see, we can see the left main stem, and we can see the circumflex and the LAD here. So what's interesting is that's quite low. So we're at the level of almost the sewing ring and the leaflets and the struts of the valve to where you see this. So that's an important bit of anatomy to be aware of. And as we move down, we're following this blind ending pouch down. We're going to keep following it down, and then you come into the outflow tract, and you can see here this friable bit of tissue. We suspect that's a bit of suture that's come away, and it's probably come away from this end to the away from the patch. And as it's torn, it's caused this defect that we've seen. There's a bit more though, because as we go further down and into the outflow tract, what's really interesting is as we enter the left ventricle now, you can see the cursor is here. This is what we're looking at. There is an area, a region here of the lateral wall that appears to be aneurysmal and thinned. And it's also causing a little bit of a sac. So let me just show you this on 3D. Hopefully I'll be able to do this live and demonstrate the anatomy. So you can see, here's the aortic root. AVR here. You can see that bit of suture flicking about just under there. So I'm going to move the picture a little bit. So what's amazing is, as you see the valve here, so if we look at it face on, if I'll rotate it a little bit like that, you can see where the sewing ring of the AVR is here. And what's interesting is it's essentially broken away from the patch here. Behind it, you can see that this patch has this blind ending region, but actually it's quite extensive. It carries on around behind. So I'm going to lift the picture up. It carries on behind this region, and that's that region here in the lateral wall that's thinned and forming that sort of aneurysmal tissue. So there's the mitral prosthesis. Behind here is where the aorta would be, and the AVR is down here. So just to get your landmark. So this is looking into the left atrium, and you can see this is the defect that we were looking at. But what's interesting is if we put the color back on, not only are we seeing this defect, so here you can see it sideways. I hope you can appreciate LVOT through the hole into the left atrium. But not only have we got one hole, because when we did the TOE a few weeks ago, we only had one hole. Now, unfortunately, it looks like we've got a second one here. And I hope you can see that as well. And the measurements are coming out is for this measurement is about 11 by 7-8 millimeters, so relatively circular. And this is about 3-4 millimeters, but I'm going to do a little bit more measuring as we go along.
That's fantastic, which is superb echo. Okay, so we did a left coronary injection, and the eagle-eyed will be able to spot as we play through that both the proximal LAD and in particular the proximal circumflex have systolic compression. So that expansile sac that we have is definitely affecting both of those coronary arteries. Now, this morning, I had a repeat CT scan done, the last one being in December, and the pseudoaneurysm, this sac, has not changed in size at all, and that compression was also present without symptoms in his coronaries on that CT scan. So we'll hopefully be able to show you the CT scan. Next shot, please. So you can see again the circumflex compression is quite profound, the LAD less significant there. Keep on going. The right coronary artery is absolutely fine. So I think the demonstration of that is that we have the pseudoaneurysm, which may well close at the same time as we close the mouth of the paravalvular leak. But actually, it's be quite important to be sure that we are looking at that pseudoaneurysm. I don't think I want to poke a wire into it to try and seal it off. I think it's got a very wide mouth, and I think that's not going to work. But as we treat the, can you orientate us, Bushra, on that echo? So go to echo. Okay, yeah. So if we go to echo, okay, so the aortic valve in that view is at 12 o'clock.
Yeah, that's right. Is this a surgical view? Yeah.
So this is a surgical view. So this is our standard clock face. So at 12 o'clock is the aorta, and that's where our hole will be. At 3 o'clock is the intra-aortic septum, which will be important in a second as we do a transeptal puncture. At 6 o'clock is as posterior as we can go. And at 9 o'clock would be the left atrial appendage, which is up there. So in this view, the deficit, the defect, is where? So you can see that. And the second deficit?
Somewhere there.
Yeah, is a little bit further across.
It looks more like a paravalvular leak, but it's still within that patch, you know,
So you can see the major hole is clearly that one which is in the 12 o'clock position, which is exactly where you'd expect it to be. And then about 10 o'clock, 11 o'clock would be a second one. So our next game is to actually do a transeptal puncture. Why? Well, what we want to do is to be able to snare any wire that we get across. And so, of course, we could try and cross this antragradely and then take it through the aorta and snare it that way. But I'm going to try and do retrograde, snare in the LA, make a rail, and then see if we can close the defect. That is about 1.6 by 0.8, so 16 by 8. It's a pretty big hole that we've got there. And initially, we thought it was going to be much more oval, and I was going to put an AVP3 or one of the Occlutech plugs in, but this is actually looking as though if we pushed it a little, it become fairly circular. And so an ASD device might actually have the rims and the strength. And the Occlutech ASD device does have a patch in the waist, which is supposed to help the sealing. I have done that once before, and Bushra, I think you've got experience of it as well. Hemolysis becomes an issue.
I mean, I think an ASD device, because it's circular and plugging that hole with a waist, and also the advantages that you of course have the two discs on both sides that may bring all of that together, both from the LVOT side but also the LA side, and in theory could potentially exclude that whole sort of pseudoaneurysm patch area that does have quite a lot of flow going in and out of it. So I think after this most up-to-date imaging, I think that would be probably my first preference. But I think, as you say, it will depend a little bit on how it all behaves and what you can deliver through that with all the angles. I mean, I think the hemolysis concern is an absolute real one, especially with personal experience. But I think the aim here should be to try and exclude as much of area as possible, hopefully with one device at the first go.
We can see the needle in the middle of the septum, okay, on the anterior posterior view, which is away from everything, and that looks a very good position. I think we should be through there. So there's a big dent occurring, but I think it haven't quite popped through as yet. So we'll maintain the pressure and try and just advance the sheath. And I'm just being careful that as we let the heartbeat get this through, as soon as it pops through, I'm going to pull the needle back. So you can see it's quite a tough septum post-surgery. And I think we've got a pretty decent position. I'm most worried about that pseudoaneurysm. I think we're away from that.
Yeah, looks like it.
And I'm pushing fairly hard now on the septum to get it to go through, and it's not doing it. So I think I might maintain this position and just get the blade in. It looks as though it should be through, but it hasn't quite moved in the way that I want it to. It does look as though it's gone through. So I think I'm now miles away from the aneurysm. If you can just make sure I'm not poking the aneurysm.
No, you're not. You're
Great.
above it, quite above it. You're near the vein now, the pulmonary vein. So
Yeah,
I don't
that's
know whether
fine.
you're
Okay,
actually
so
in it, but
I'm going to leave that there. Have you got another clip for me? Great, so we've got that settled down. Now to cross the valve, I think a pigtail is safer. So we've got a 10 French sheath, sorry, 12 French sheath, beg your pardon, and we're going to try and get through that, which we have with the wire. Okay, so I can see where I want to be when I acquire, and when I'm just fluoroscopying, there's absolutely no hope of seeing that. So, oh, I've got my eye in. Okay, so that's a maximum fluoroscopy, so we'll take the catheter through.
Okay, VT again.
Okay, hang on. So I'm pulling back. That will settle it down.
Yep.
So where is that? And that's not wanting to go. Is that the wire still in the pseudoaneurysm or
yeah,
nowhere?
it's caught up inside it. Can you see? I can't really see it in the other view, but I can see it in this view. Can you see you're there? So you've gone up into this direction here.
Yeah, I got it. Okay,
Yeah.
so it's still too low. So I'll rotate again. It's still caught, isn't it?
Yeah.
You're still in that space.
Yeah, so I don't want to push too hard in that space. Now, this is looking better. This is lower. And if I rotate, now that's very close to where I want to be.
Yeah, you're coming back gradually. Can you see you're curving in the right direction?
Yeah, so where is that wire? That's still not gone through to what I want.
No, it's still just... It's going under the mitral valve at the moment. It's like you need to come back just a little bit more, because as you go forwards, the tip is somewhere here. That's it. Now you're nearer. Can you see it's moving now?
Okay, so here we are. We're going to have to shoot it. So I'm doing it mainly on echo because I've got to hit it.
So Iqbal, just to give you an idea, so you're looking at this, which is fine, but when you look in the other view, the wire is tending to go in this direction. So what you want to do is, it's actually here, the hole. It goes diagonally though. So I don't know whether when you can control it a bit more when you get to here, just to watch that movement, because that's how you'll get, it's here. So there's a tip to the wires there. So you're right over it, but it's almost like you want to go backwards a little now.
Yeah, that won't be this catheter.
Yeah.
So I think this may be a Taruma situation. So.
Yeah.
Oh God! I think it flicked for a second. I've got the feeling
you're so close. The tip is just there, and it's just a case of if you went that way rather than kept going that way.
So you see that? If I could get it to keep on going in that very small turn, you see what I'm talking about, Neil? It's just as it goes horizontal.
I think you actually prolapsed it. Like, I think
there we are. Okay.
Yeah, saw it.
There we go.
Grab that fluoro.
Okay, good. So we're going to rotate that up into the atrium. So come back a bit. Sorry, come back a bit. Okay, I'm just going to take a cine of that. Okay, so we're definitely not through the mitral valve. Okay, and now, Bushra, take your time with taking some pictures of this.
Well, I caught you going through it.
Fantastic. Okay, so it really is just getting the eye in on where the hole is and then throwing a dart at it. So that's exactly what we did. I saw it flick a few times, and so then we pushed forward as it was flicking, and that's got us into the right position. Okay, so you've got the trefoil snare. That's what we're going to try and snare through the Achilles sheath. Okay, fantastic. So we're going to copy that up. Now, Taruma wires love to move, and so we want to be sure that we do not move this Taruma wire. Okay, so the question is, oh, that seems to have grabbed a piece of the tip of the wire. Okay, so we've snared the wire and we've pulled it in. So what we need to do is to draw the wire out. So let's just see if we draw that as a unit. Have we got enough of it? We've got a kink in it now inside the catheter, so it should be fairly firmly gripped. Now we've got a snared wire. Okay, and we can feed this wire up and pull this out so that we've got a loop available. Okay, so I'm going to feed slowly and you're going to pull. So keep on pulling. And what we're doing is we're feeding the wire out, so we've got a rail. So we're going to have to go at the same pace. So we've got two clips on the wire that's been pulled out through the Achilles sheath, and we've got one clip that's holding. So we've got a rail on an exchange length wire, and what I really want to do is to be able to deliver a sheath retrogradely, because I think it would be more stable retrogradely than. Okay, so to give you an update on where we're at, we've got a buddy wire that we've put in through the hole, and we haven't got a device that has a long enough sheath to actually go retrograde. So we're going to go antragrade, which we will see how that works, because it's going to have a fair amount of tension on it. So we're going across. So we need to just put some tension on that wire as we go across. Wow. So I'd like to really push.
Shall I press both? Shall I pull both?
I think pulling, that's probably not needed, because I want it to actually prolapse down into the ventricle. Okay. So I'm going to try and deliberately push it into the ventricle. There we go. Okay, because I don't want it to go across the aortic valve. So that's across. So what I want to demonstrate is the device. Okay, so it's got a waist and it's got quite a big skirt on it. Okay, and this is a pretty big meaty device. Okay, but this is the biggest thing that will go through the 9 French sheath. Okay, so we've attached up. This is at the moment silver. Okay, so we're going to push it in until we've only got cable, and just to make sure there's no air bubbles ahead of it, we're just going to make this solid red. And if this is solid red, which it's becoming now, then there can't be an air bubble ahead of our device. Okay, so I'm comfortable with that. Right, so I'm just going to use fluoroscopy to take this up. And I want to be gentle because I don't want this catheter to fly as it goes through. Okay, so that's gone through. So you can see the first disc is sort of out and it's taking a bulbous sort of shape. Save it. Okay, fine. So we can see that the first disc is out. So the 2 gold markers are on the short axis. So if I can see both gold markers, I must be looking there. If I can see them in a line, then I must be looking at the long axis. So given that the 2 gold markers are on the short axis, so seeing them together, we're seeing the long axis. Seeing them apart, we're seeing the short axis. Okay, so let's see what the fluoroscopy actually shows. So play the fluoroscopy. Okay, you can see the two gold markers are separated. Okay, so we're looking down the short axis of the device. Okay, so the question is whether the orientation is correct or incorrect. So I'm going to draw it towards the ventricle, towards the spot I want to deploy in. Okay, so let's move it a little bit closer.
Let me just show it to you
without pulling it out. Okay,
yeah.
So that's getting closer and closer to where I would want to deploy it.
Yeah, and I'll just find it on the 2D, just so I've got the understanding of it. There it goes.
So that's the problem. If we had the retrograde approach, then seeing one of the discs in the LA, very easy. This is very difficult in the left ventricle.
Close enough.
There you go. Yeah. Okay, that's it. So that's looking like the long axis. So I want to orientate it along the mitral valve annulus. So that looks as though it will do it.
It's lying like this at the moment.
And
so
where's
as
the
it
annulus?
gets closer here, the annulus is there, in that direction. So it's 90 degrees to the way you have it currently.
Okay, so let's see if we can rotate and get any movement out of it. I think I'm going to have to take the whole device out. So I'll push it out. Okay, so we're quite a long way away from the mitral valve annulus. Okay, fine. So we'll recapture. Okay, so now we've got the disc. I'm going to bring the disc down. Be brave.
That's it. You freed it now.
Okay, so how's that doing?
So it's looking good. I think when you get closer, you'll maybe a slight rotation, but you might be okay. Can see the angle it's coming in slightly kind of
I think I've got
tilted.
only one disc out. Okay, even though it looks like on your echo it's two, I think it's only one disc.
I think it's only one disc you've got out there.
Yeah, okay.
It's just the drop out from the sheath above it that's
so
causing
if I
that.
rotate the sheath.
Yeah, that's it. That's that's better.
Yeah.
So you've rotated it. Can you see above?
Yeah.
If I just show you here, let me just turn the gains up a little bit. So you can see that the sheath, actually that looks good, doesn't it? Because it's lying like this, isn't it?
Yeah, it's lying longitudinally there, I think. Can we, am I making that up, or do you think that's correct?
No, you're not making it up. Can I just go to the 3D now? We're closer, so that should hopefully show us.
Oh yeah, that's good.
Yeah,
that's good. I see the device.
Yeah. And it looks like the orientation is correct. So that's the LA sides. So yeah, so there is a disc. It's funny, it looks rectangular there, doesn't it?
Square. I mean, yeah, it looks square.
Sorry, square.
Yeah.
I mean, so it looks square there, doesn't it? I mean, its position looks good. I think you just take it back.
So I'm trying to rotate it more. The dots are more aligned than they were, so it has rotated.
And you are along the line of the annulus here.
Okay, so I've got a lot of rotation on. Okay, and so I'm on the annulus, I think. So are you happy that I am on the annulus from the LV side?
I'll tell you.
So if you do 2D and see how we've caught the aortic and mitrals. And I don't want to catch the, I think I'm below the aortic, so I think we should be all right.
Yeah.
So see, I think that's caught. I can see that is caught on that ledge of the Saurian crown.
I'm just
below the aortic valve.
I know you're distance away actually. Look, so you know you've got tissue here.
Yeah.
If I move there's the edge of that big lump. There's another edge there, so it looks like you're not quite caught it there. You haven't quite caught it.
Yeah. So I'm just going to push in a bit. Okay, which it's allowing me to do just about. Okay, so I've just rechanged my orientation. And I think I want to rotate it a bit more personally. So I'm going to push through a little bit more and see if I can rotate this.
Just going to look for you.
These are very difficult to rotate, these devices.
Have you got both
discs out? Yeah, look.
You got both discs out?
Yeah, okay, so that's both discs out. Okay,
Yeah.
so that's because I was pushing forwards.
Oh, okay.
Yeah.
So now we'll recapture one. So you saw that oh, hang on, what happened?
So I flipped it to the right way round.
Okay, so we've recaptured one of the discs.
Yeah.
Okay.
Yeah.
And then I can't see on echo where I'm going to deploy
Yeah,
this
I'm
device.
struggling. There it is there.
Okay, so there we are. That's got the long axis of the thing. So I'm going to pull down. I'm watching the echo. I'm going to pull down. There's quite a lot of tension on that now. I'm still pulling. Okay, so now that makes me think it's a miles away. So why does it make me think that? Do you think transgastric would help?
I can try.
Just to see if that helps with the LVOT picture,
Yeah,
just
let
to
me
give
just
it
see
something
if this
slightly
gives
different.
us some information. So
Is that the okay? So that's the device. Yeah, you got that. That's the LVOT view. Yeah.
Yeah. So there's
Okay,
the
so
LVOT
stay there.
there.
Stay there.
Okay,
So that's
there's the defect there. And just to show you, so this is where the valve. You know, all that ledge of tissue is. Aortic is here.
Yeah.
And there's the hole in
Yeah,
between
fine.
them. Yeah.
So the whole orientation is not quite right there, is it? So just stay there because I've got my eye in, and so now I'm just going to rotate. It's looking as though it's working. It's rotating into the right sort of position. There's just going to be a lot of tension on it. That's the problem, and it might ping. Okay, so that's good. That's good. So it's coming down slowly. Okay, so that's looking as though it's really on the mitral annulus. Okay. And auto cool imminent. That's not useful.
Yeah, just ignore it.
Okay, so what I'm going to do is try and deploy the other disc. Okay, so I'll have some tension on it.
So if you deploy the other disc at this point,
Yeah.
You're still in the outflow tract.
You reckon?
It doesn't look to me like you've opposed.
Okay.
Or does it look like that to you?
It looks on fluoroscopy. Can you open up the tops and bottoms a bit? Thank you. So, to be honest, it looks
fine. That's fine then.
It looks okay.
Or maybe if you go to 2D, because maybe there's
can
tissue
you go
there,
2D,
that might be drop out.
Go 2D.
Yeah.
Okay, and just see how far away we are, because
that might be just drop out from tissue. Yeah, look.
Oh yeah, no, you're right. You're
right
look, you're right up against it there. And that's what I was looking at. Actually, it hasn't quite. There you go. That's good. Look, there's that nubbin of tissue.
Yeah. So it hasn't quite caught it.
Yeah.
Okay, so I'm just going to advance it a bit and see if I can catch it without disrupting everything. Need to flick it. That's it. Okay, that's flicked over the nubbin of tissue. Okay, so I'm going to try and maintain tension with that.
Yep.
Okay, because that's caught on the edge.
Yeah.
Okay.
Yep.
And so that's where I think I want to see if I can leave it there.
Yeah.
And take that's a bit too far away. I'm pulling. Okay, I'm pulling.
So hopefully
I'm deploying the second disc.
You're not quite through to the left side yet, left atrium side yet.
Oh yeah, okay, fine, I got it. Okay, so it was almost there, but not quite.
Yeah.
Okay, so we'll try it again. Keep the tension on. Oh, it's a lot of tension on it.
Oh yeah.
Okay.
That's caught it.
Oh, that looks good.
That's caught it. Yep.
Save it.
I will double check, but it looks like to me this is the LA disc.
Yeah.
And it's distorted because it's being pulled in such an acute angle. It wants to sit down here and this way, and the other disc behind it is there. Can you see that?
Yeah.
So I'm just going to look at the other side.
So what we're going to do is just push on this a bit with the cable.
And I'll just double check it with 2D too, just to be sure.
There. Okay. So what's that done to it? So now it looks a better shape. Yeah.
It does look a better shape. It's beginning to look a bit more like, and it's sitting exactly the way we'd want it to sit.
Yeah,
actually.
absolutely.
So let me just
So the question is there another gap? Yeah.
Yeah.
Which we can see. Yeah. So there's a gap next to it. So no, other side where the wire is. Other side.
This side.
Yeah. So
I see where the wire. Yeah.
So there's a wire. So if can we do a 3D color there to see where the color's coming from?
Yeah.
Yeah. Okay. So that's where the wire is.
Yeah.
So before we release this device,
It's all
I'll
coming.
put a torque
Yeah.
view up on the other side. Huh. Okay, so there's a big hole there still. Okay, fine. So we've got a sheath through, okay, by the side of this device. So there's the sheath, you can see it, yeah?
Yeah.
Okay.
This looks like it's the. Is this the other hole, or is this on this side of it?
Well,
It looks like another hole, so
yeah, we said
we
there
might
was
just shove a device in there as well.
Yeah.
So, okay, so that's well across.
And you could interlock them, couldn't you? I guess.
Exactly. So
Give them some stability.
let's take that out. Okay, this is a 7 French. Okay, so let's keep control of all of that. Okay, let's stick a syringe on there.
Okay, that's a long
while we
journey.
acquaint ourselves with what we're going to do here. So I am thinking that this is okay. Well, I mean, it went through easy, so there's a hole there for sure.
9
so we
by
need to put
5. I'm getting
for the
roughly.
biggest device.
yeah, go for a bigger device that we can go. So let's get the AVP3. Okay. So the 14 by 5 will go through. And so it's got much smaller waist, so the chance of it pulling through are definitely higher. It's another rectangular device, and I'm not expecting this to look anything like this once it's inside the body. It's going to be a pretty mangled mess. So what we're going to do is we're going to draw it in, and hopefully underwater. Okay, so can you hold that like that, Neil? Okay, fine. So underwater, we'll pull it in. Okay, there's no need to recheck that device. That's always fine. And we've got a flush syringe. Okay, and so I'm just going to flush the top in. There's no easy way of flushing it, but you can see there's water coming out of there. So this is well flushed. So we'll take that over to the table, put it through the torque view sheath. And here comes the device. You're on the triple view, yeah? Okay, so I'm going to take the disc out. Okay, so let's just take a picture of that. Okay, so the first disc is out. I'm going to slowly withdraw. I'm pulling that up. So Bushra, can you just focus on the 3D?
I can't see the LA.
Yeah.
There we are. Okay, so you can see the device coming.
Yeah. There it is. Yeah.
Yeah, so you can see the device coming. And let's just see what the 3D of that looks like.
Yeah.
Oh, look at that. Okay, fine. So that's looking the correct orientation.
Yep.
Yeah, so
Yep.
definitely. So when we actually plant this, the other disc from the ocular device, I'd like to cover it over the top. So that looks fine. And I think that's a correct orientation. Would you agree, Bushra? I don't think we want to change that.
Yeah, no, I just put the colour on just to show you. So it's interesting because there's a bit of space here.
Yeah.
And there's also this defect here.
Yeah, so I think that we'll wait for another day.
Yeah. So
the question is whether if I rotate the device long ways,
yeah,
whether that would actually be helpful for that leak there. So
I wonder
I'm
whether
going
it
to
will.
just push on a bit and rotate. So keep it, and let's just see if it will turn. So I'm rotating the catheter because I can't rotate this device. So it's turning slowly. You can see it turning.
Yeah.
So I'm putting the torque on.
Might be getting caught because it's quite near the other device, isn't it? It's resting on it.
Yeah,
Oh, yeah.
that's fine. I think it'll bed itself in a minute.
It's turning.
So I like that.
Yeah.
Okay. So what do you think of the color there? Put the color on.
Yeah, it's definitely catching it now, isn't it? Before it wasn't. Yeah.
Okay, fine.
Definitely
So I'm
catching
going to
it.
maintain the tension on that
So I'll take
and
the colour
pull it
off.
up. Okay, so I'm pulling it up. So now it's caught tight against it. Okay, so I'll release the other disc. So that'll be on the LV side. Okay, so I'll release the other disc, keep the tension on. No, just wait there.
Yeah, okay.
Because it's fluoroscopy really that I'm doing. So, okay, so I've released both discs. So now let's see what we've got. Okay, so what we can see is that our initial LA pressure was about 70, 75. And now if we go to live, it's about 50. And the systolic pressure is still the same. So I think it's significantly improved the mitral regurgitation, judged on the V-wave. And that's even before we've released the devices. So hemodynamics is fine. Bushra, let's talk through the echo that we're seeing.
Let's just give you a 3D of that. So this is the LA view, so the surgical mitral valve view. You can see the mitral prosthesis in the background. Aorta is here, so just to give your landmarks, you've got your 12 o'clock aorta, LA appendage, just a part of it you're seeing there. And if I rotate the probe, you'll see the atrial septum just coming into view there. So you can see here, you've got your two devices, and I'm going to just rotate the image slightly just to show you. So this is the Occlutech device, and you can see it's still held in place, and this disc is distorted. You can see this disc up here, rectangular disc, and you can see in the distance on the LV side, the other disc. And this is only distorted because it's under so much tension. You can see that, and nicely the AVP3 has been tucked in under here, and you've rotated it such that if I put color on, there was quite a lot of leak coming out from underneath all of this, but actually a lot of it's disappeared now. So you're seeing the flow through the valve itself, but in fact that very large leak we were seeing on either side here and here has got significantly less just by even putting this here. So hoping that when you release this device that it will look better, and as it gradually shapes that it'll look better too.
Okay, so let's do the LV side.
Yep. So let me take the color off. So again, just to give you some landmarks first. So there's your mitral valve there. You've got your LVOT in the distance, which is just there, here in the distance. There's that region of tissue that had torn away from the aortic valve, just here. You can see that irregularity here, and you can see that this is the Occlutech device here, and I think I can see just tucked in sort of sideways there is the AVP 3. I'm just double checking. Yeah, it looks like that's it. Yeah. Don't know if you can believe me when I say that.
It's tough, isn't it? That's tough. Okay,
Yeah.
so let's look on fluoroscopy, and I think on fluoroscopy that does look as though you're exactly right, that the two devices are interlocking and moving. So before we release, can you go and show us that pseudoaneurysm in the LVOT and see what that looks like now?
Yep, so there it is there in this view. And what I noticed actually was that you had a lot of turbulent flow before, and that flow has significantly subsided actually. It just, you can see just low velocity flows, so that you've got blues and reds, which means that it's very low velocity. There is flow through the device, but hopefully that will improve as they are released.
Yeah.
But in terms of this outflow tract, I think it looks already a lot happier, and hopefully this won't cause any issues.
So now we've got a choice. I think I'm going to release the Occlutech device first because I think I want to see how that shapes. And as it releases, as Bushra said, the tension on the device disappears. The device sits down better. The two discs look good. And actually, the left atrial disc is above the AVP3 disc, so it should interlock nicely. Okay, so if we look at the two-dimensional view, okay, of that LVOT and put the color on, I'm pretty comfortable that there's a leak going through the devices. But it's nowhere. Well, actually, there's still a jet that's pretty large.
That's the other. Remember, we said there was another jet.
Oh, that's the other hole.
That's
okay,
a completely
fine.
different hole. Can you see that? It's
yeah,
near
so
it.
That's a separate.
But that's something to review. But this is already more than 50% easily.
Yeah, I think so. I think the other hole, we know how to cross it. I think the team's getting a bit tired, and we'll see how he does with this.
Yeah.
So I'm going to release the other cable. So we're going to put the screw on. Okay, fine. So we've now released it as well. We've got nothing across the aortic valve, so the AR should be better.
Yeah, so
the MR looks good.
The MR through the devices looks amazing. There's hardly anything. There's just small jets.
So we're just going to pull that out of the atrium.
Just setting IVC, but just not on the left side.
You can see the other defect that we've talked about, but that's another defect for another day. The AR's gone. Aortic valve looks fine.
Yeah. So
okay, good.
J1.
So it's safety checks from Bushra, and what we're going to do is we're going to close up and the closing up part of it will be, we might as well do it in stages. Let's get the venous sort of situation sorted out first. Can we have some protamine, please? Okay, so
that's for the aortic.
That's for the aortic. So you got the wire.
So it leaves us to close up to say we've had a great day, and thanks to the team at the Hammersmith Hospital for doing this. Neil, great job with the case. Bushra, beautiful imaging.